Good evening, everyone, and welcome to tonight's Scleral Lens Education Society webinar. A quick thank to all of our sponsors of the Scleral Lens Education Society and of this webinar tonight. Our diamond sponsors include Art Optical, Advanced Vision Technologies, Bausch & Lomb, and Blanchard Contact Lenses. Our platinum sponsors include AccuLens, Alden Optical, Conomac, Essilor, Menacon, OptiView, Paragon Vision Sciences, Synergize, Trueform Optics, Visionary Optics, and Excel Specialty Contacts. Our silver and bronze sponsors include Boston Foundation for Sight, ABB Optical Group, Visionary, Easy Lens Applicator, Today's Vision, and Valley Contacts. Our two presenters tonight are Drs. Mellissa Barnett and Dr. John Gelles. A quick bio on each of them. Dr. Mellissa Barnett is the principal optometrist at the University of California Davis Center in Sacramento. She is an internationally recognized key opinion leader specializing in anterior segment disease and specialty contact lenses. Dr. Barnett lectures and publishes extensively on topics including dry eye, anterior segment disease, contact lenses, and creating a healthy balance between work and home life for women in optometry. She is a fellow of the American Academy of Optometry, a diplomat of the American Board of Certification in Medical Optometry, a fellow of the British Contact Lens Association, and serves on the board of the American Optometric Association, the Cornea and Contact Lens Council, Women of Vision, Gas Permeable Lens Institute, Ocular Surface Society of Optometry, and is the immediate past president of the Scleral Lens Education Society. Dr. Barnett is a spokesperson for the California Optometric Association and a guest lecturer for the Staple Program. Drs. Mellissa Barnett and Lynette Johns edited the book Contemporary Scleral Lenses, Theory and Application, with the unique perspectives and contributions of international experts. Dr. Barnett was awarded the inaugural Theo Award for Excellence for Mentoring by Women in Optometry. In her spare time, she enjoys cooking, yoga, hiking, and spending time with her family. Todd Erickson, also an optometrist, and her two sons, Alex and Drew. Dr. Gelles is the Director of Specialty Contact Lens Division at the Cornea and Laser Eye Institute, Hirsch Vision Group, and the CLEI Center for Keratoconus in Teaneck, New Jersey. His clinical work is dedicated exclusively to specialty contact lenses and surgical co-management for corneal disease with an emphasis on keratoconus, ocular surface disease, and post-surgical corneal conditions. He's also the Chief Emerging Technology Officer at Eye Care Live, a graduate of the Pennsylvania College of Optometry, and is an adjunct clinical instructor for State University of New York College of Optometry and the New England College of Optometry. Additionally, he is an optometric consultant, active in clinical research for keratoconus and specialty contact lenses, and is involved in multiple academies, societies, and associations. So with that, I will go ahead and turn it over to Dr. Barnett.
Well, thank you all so much for coming tonight, especially at this busy time of year. We are thrilled to present this webinar to you tonight, and we're going to talk about scleral lenses in ocular surface disease. We are fortunate to work with many companies, both John and myself. So scleral lenses were reintroduced into the market really in the 1980s. So they were actually the first type of contact lens ever to be introduced in the late 1800s, early 1900s. But in different parts of the world, they were reintroduced. So we have to thank Don Ezekiel in Australia, Perry Rosenthal of the Boston Foundation for Sight in Boston, in the US, the Visser Whole Group in the Netherlands. Oh, they've done so much wonderful work regarding scleral lenses, and Ken Pullum in the UK. So we know that scleral lenses have grown so much in popularity, especially in the US market, and they're beneficial for patients who have irregular corneas and to help correct that irregular astigmatism, and also for the treatment of ocular surface disease. So today we're going to talk about the treatment of ocular surface disease. Now, there are multiple studies out there. Some practices, really their main indication for scleral lens wear and scleral lens fitting is ocular surface disease. Other practices, their main indication is for irregular surfaces of the cornea, like keratoconus, keratoglobus. And in my practice personally, and I'll let John comment as well, it's really a mixture of everything. So it's irregular corneas, it's the severe ocular surface disease, and also in my practice, normal corneas as well. John, what about in your practice?
Typically a strong mix of irregular corneas. I'd say 80% is irregular corneas, being that we do have the Center for Keratoconus, and then the other 20% is severe ocular surface diseases like what you see down here. Been fortunate enough to work with both two very skilled cornea specialists, as well as a ocular immunology and inflammatory disease specialist. So we see a fair amount of these really advanced ocular surface disease cases.
So when I lecture on scleral lenses, sometimes the participants are surprised about the ocular surface disease indication. And that's why we really wanted to focus on this group of patients. So there are so many patients out there, and actually in my clinic, I feel like the numbers are really high, but if you look at national statistics, for example, of graft versus host disease, the numbers are pretty low. So conditions like graft versus host disease, which is a complication that can occur after a stem cell or bone marrow transplant, and where the newly transplanted donor cells attacked the transplant recipient's healthy tissue. Now, these patients are miserable. They are just coming in crying. Absolutely miserable. And fortunately, scleral lenses have provided relief from their severe exposure, their dry eye. They can have scarring and some blepharon. Stephen Johnson is another group of patients that we see, and it's just a severe form of toxic epidermal necrosis, a severe hypersensitivity reaction. This is another group that is just completely affected, and they come in completely devastated oftentimes because of their severe ocular surface disease. We could go into each in detail, but what we're talking about, we can even talk about the Sjogren's patient, and I have a special interest in Sjogren's syndrome, and it's not listed here, but I do want to bring that up because these patients can benefit so much from scleral lenses. So actually applying the lens in the office, patients have begged me, please can I take that diagnostic lens home with me because it feels so great. It's really life-changing. So scleral lenses are really life-changing, but especially in all these patients. Limbal stem cell deficiency is another indication for scleral lens use. And those patients that are, say, abusing soft contact lenses, sleeping in them, who have developed limbal stem cell failure, and you might think, well, that's kind of counterintuitive, putting a scleral lens on an eye where you're discontinuing soft lenses, but scleral lenses can be really beneficial. I find especially in the younger patient population, late teens, early 20s, they respond really quickly to scleral lens wear. And just a word of caution is to educate patients regarding the hours of scleral lens wear in this population, because they're the ones that could have been wearing their contact lenses, sleeping in them, abusing them, wearing them really 24 hours a day, and setting some sort of limitation. And I'm not saying, a short amount of time, but really telling them, 14, 16 hours of wear, that's all you get with the scleral lenses. So scleral lenses are used to protect the ocular surface. So it's really the post-lens tear reservoir that's the magic of scleral lenses. So it corrects all the corneal irregularities. It bathes the corneal surface and the ocular surface all day long. For example, a patient with a persistent epithelial defect, steroids can be used in conjunction with antibiotics to help heal the surface. They prevent mechanical damage, they prevent the tissue from desiccating, and they help with healing. And also in the patients who have really significant ocular pain, and a patient can come in with significant ocular pain without staining, it disrupts the pain cycle, makes them much more comfortable. And we always want to see, what is the risk-benefit ratio for each patient? And this is each patient just in general, but especially in this severe ocular surface disease population. Is a scleral lens the best option for the patient? Could we have another option that could work better? It is the most important to understand the underlying systemic condition and also working with specialists. So for example, I brought up Sjogren's. I work very closely with rheumatology. And if a patient is having a systemic flare, that can really affect their eyes. So I always like to ask my patients, are you going through a flare currently? Have you had a recent systemic flare? Because that really can affect the amount of ocular inflammation and the fit of the scleral lens. We work closely with other specialties as well. So oncology, for example, if a patient is on any sort of systemic steroids, it's helpful to know that too. We want to monitor their eye pressure and also monitor their ocular health. A recent patient of mine, I sent her to an allergist. She has severe allergies. The allergist agreed and started allergy shots. Now, this was also at the time we were fitting a new scleral lens design, which was really not the best timing because her eyes were so inflamed due to the allergy shots. Fortunately, she sort of got over the hump, her ocular inflammation reduced, and then we continued the scleral lens fitting. But working closely with all specialists is really critical. John?
Oh, yeah, absolutely. When we look at, taking a multidisciplinary approach to these individuals are not your typical, keratoconic who comes in, has no other systemic diseases, just has an irregular cornea. These individuals are coming in with rheumatic disease, various inflammatory diseases. They are individuals who are systemically ill, and being able to take care of that systemic problem and use a scleral lens as an adjunct to the therapies that they're currently using is extremely important. So being able to take that multidisciplinary approach, like in our clinic, we have, I'm fortunate enough to work with a ocular inflammatory and immunology specialist and uveitis specialist, and be able to co-manage those patients who, may be on, autologous serum and compounded cyclosporins and tacrolimus and, Humira and all these other things, and really making sure that we're able to provide full coverage to that individual. So if they are having a flare, we get that under control quick, and we're able to really improve the healing properties of the ocular surface by using that scleral lens in conjunction with the other therapies that we're doing. So when we take a look at risk-benefit ratios on these individuals, I tend to find that for these individuals, we exhaust our other therapies. We'll end up going through, autologous serum every hour, and preservative-free artificial tears every hour, and systemic steroids, systemic immunosuppressants, and various different treatments, and we're still not getting to the point where we have a cornea that's, one, healthy and functioning properly, and two, having a patient that can be comfortable and function. So we really look at, have we exhausted all of our other therapies that would be more simple first? And then it comes down to a pretty simple choice in the risk-benefit ratio of, a scleral lens versus a high-risk surgery, such as, needing a high-risk penetrating keratoplasty, such as that individual on the bottom who suffers from pemphigoid. We can see that those individuals, if we can put them into a scleral lens and save them from having to go through a high-risk surgery, we can typically make things quite a bit better with that scleral lens and that therapy. We can also avoid other sorts of surgical interventions, such as keratoprosthesis for individuals who have failed multiple grafts, or have inflammatory melts constantly, or using partial or full tarsorrhaphies, or even Gunderson flaps. So Melissa, I'll go ahead and turn it back to you on kind of mild to moderate disease here.
Right. So some patients, they've tried everything that John mentioned, including punctal plugs and lubricant ointment and goggles at night. But this patient population we're referring to, scleral lenses are an option. And here I'd like to bring up that we need to refer to our colleagues for scleral lens fitting and care. I don't expect every single one of our colleagues to fit scleral lenses, and that's just fine. But establishing a network is really beneficial. So if these patients have tried other alternatives and then they find a scleral lens specialist that specializes in lenses, they can be the ones performing the scleral lens fitting. So even in mild to moderate dry eye and ocular surface disease, scleral lenses are quite beneficial. So I do fit scleral lenses on normal corneas, those patients with refractive error, with astigmatism, presbyopia, and dry eye. And scleral lenses help bathe the ocular surface, so they help with dry eye. They can correct astigmatism and fit them with a multifocal scleral lens. It's really fun and fantastic. But it's great to talk to our patients. Say someone who has mild ocular surface disease, perhaps there could be a modification, and I'm not talking about any of these other conditions that we've just talked about, but just mild ocular surface disease, dry eye, meibomian gland dysfunction, addressing that first and perhaps switching them to a daily replacement soft contact lens versus a monthly replacement lens, not sleeping in the lenses, changing the care system to a peroxide-based system. And this is all going from the TFOS contact lens discomfort classification. And also we want to talk about vision. Gas permeable scleral lenses provide really crisp and clear vision. So for some people, that's a real benefit. But it's very individualized. So for each patient, it really does, the treatment plan really does differ. So it is important to address the ocular surface disease, address any meibomian gland dysfunction, blepharitis, Demodex, all of that, and consider other options. So scleral lenses are not necessarily the first option that I choose in my practice. Next slide.
Perfect. So some common challenges that that come up along with these, and that kind of plays into your patient selection for those individuals who may have mild to moderate disease, and certainly challenges that you're going to see with individuals who have severe and advanced ocular surface disease. These things tend to come up quite often, which is lens awareness and chamber debris and issues with impingement in these larger diameters that we use to cover the ocular surface, as well as pore wetting and deposits building up on the front surface. So all these kind of amount to the challenges that we tend to see with individuals with these ocular surface diseases. And we'll go ahead and dive into these in various forms here. When we look at the cornea and ocular surface, really what we're looking at is, various different patient complaints that will help tie us into clues that'll say, hey, this is a corneal issue versus, hey, this is a lens wetting issue versus, hey, this is a problem with the post-lens tear layer. Really what we're looking at are things like increased halo and blur as wear time increases, and finding that resolves after discontinuation of wear. So once they take the lens out, about an hour afterwards, the cornea goes back to being somewhat clear. They may tell you that they have a rainbow effect around lights, and that's caused by some diffraction that can happen in these very fragile corneas. One thing to bring up is that many of these individuals who have undergone penetrating keratoplasty or have undergone various traps, blebs, various glaucoma surgeries, these individuals tend to have more fragile endothelium, and sometimes will have frank dysfunction of that endothelium, which will lead them to swelling and being a little more fragile and needing to have a little closer care and making some pertinent changes to the way that you fit the scleral lens for that individual. Other things that they'll tell you is that they may have irritation later in the wear time or irritation after they remove the lens, but most of these individuals are certainly going to complain of irritation after they remove the lens simply because they do have a severe ocular surface disease in most cases, and those individuals with kind of moderate ocular surface diseases will have less of that. When we're kind of following these cases, one of the things that we want to see is just, can the cornea handle the stress of a scleral lens? You know, are we seeing epithelial bulli? Are we seeing edema of these corneas? Are we seeing vascularization of the corneas? Again, it comes up to bringing up that risk-benefit ratio of the scleral lens therapy. If this individual is healing nicely, but also having some minor neovascularization, is it something that we should continue? Is it something that we need to modify the fit on? Is it something that we need to say, okay, this individual is wearing this lens, 15 hours a day. Do we need to cut them back a little bit? Do we need to look at other alternatives? And kind of look at really where we are and judging how that cornea is responding to the lens. So, Melissa, in your patient population, how often are you seeing individuals who pop up with things like epithelial bulli and edema?
Yeah, so edema is a big concern, and a study we did at UC Davis on patients who have had a corneal transplant, a penetrating keratoplasty, and who have had adverse reactions to corneal edema has made me more concerned about this issue. So in patients, especially those who have had a penetrating keratoplasty and are sick or elderly, and sick systemically, so they're systemically ill or elderly, it's really important to check an endothelial cell count. Now, I realize everyone doesn't have the instrumentation, but you can just refer out to get that baseline measurement. I find that to be helpful. But I am much more concerned about corneal edema now than I ever was before, especially in this patient population. Or if there's pre-existing corneal edema, I want to get that under control prior to fitting a scleral lens. So corneal edema for me is like a red flag. I get very worried about it. Corneal neovascularization, not as much. Yes, I agree. You can reduce wearing time, you can change the fit, you can change the amount of limbal clearance if you need to. Yes, that is a concern, but not as much of a concern as the neovascularization. And just going back a slide regarding the Saddler's veil issue versus the front surface wetting, this is really important when you're triaging a patient. So for example, if they're calling in, I'm sure many of you have patients that travel a very far distance, like I do, and maybe they're coming from 4 hours away, so they can't like hop into your office that day. So if a patient just takes a flashlight or any sort of light that they have at home and shine it in their eye, if they see rainbows around light, that's concern for corneal swelling, corneal edema, so they do need to remove the lens. Now, if they remove the lens, clean it, and put it back on, that could be a front surface wetting issue. So that's a good way to sort of differentiate it. My worst nightmare is when my scleral lens patients end up in the emergency room for an issue like this, and that's a really helpful hint to prevent that. Is something you could just do over the phone, and I've done that many times. I'll even call the patient back like 15 minutes later after they've cleaned the lens, put it back in. How's your vision now? Oh, it's better. Great. That was a front surface wetting issue. That's just helpful when you're talking to patients on the phone. But getting back to sort of the corneal response, you do need to consider other lens options. I fit a lot of corneal gas permeable lenses in my post-penetrating keratoplasty group. Now more than ever, I'm reaching for a corneal GP. Even if they've tried one before, I can change the design or diameter and have success with that. there are other lens options that you might want to consider, a hybrid lens, a custom soft lens, or a piggyback lens. So, of course, every person is an individual, but the corneal edema issue just really, really worries me at this point in time.
Absolutely. I think any of those endothelial cell counts are going to become standard of care here pretty soon. When we look at scleral lenses and scleral lens fitting, we got to understand kind of what sort of choices we need to make to be able to make these individuals able to wear these lenses when it's indicated. So we need to be able to limit risk by making prudent choices. So evaluating that risk-benefit ratio before fitting these patients, especially if their corneal function is compromised, such as those individuals who are post-corneal transplantation. And we need to be able to modulate our scleral lens wear and our characteristics of our scleral lenses based on the response to wear. And we need to be able to follow up frequently and make sure that we're following up at correct intervals. What we don't want to do is have these, fragile corneas and tell them, okay, we fit you in a scleral lens, bye, we'll see you in 12 months. These individuals, many of these fragile corneas, I'll see anywhere from every 6 to 12 weeks to see how their cornea is functioning, and then if things are going relatively well, we may extend that out to every 3 to 6 months and kind of see how we're doing over that period of time before we really just say, hey, things look good, bye. We really want to be able to monitor those baselines. So being able to get things like endothelial cell counts, being able to look at optical pachymetries of these corneas, and being able to just track those over time and be able to get difference maps to be able to tell what exactly is going on is extremely important in these individuals.
And I completely agree with close monitoring of this group, but also these are patients who have oftentimes been to 3 or 4 other providers and they've tried multiple lens options and they're in your chair. So sometimes fitting scleral lenses takes some hand-holding, and it takes some education and re-education and retraining, say, for application and removal. So whenever I'm concerned about a patient, I definitely want to see them more often. If they're having any problems or any concerns, such as inserting a lens with a bubble and then not removing it, if there's a bubble because they've worn a corneal gas permeable lens before and the bubble just sort of came out, these are the patients that require a little extra care and hand-holding along the process.
Absolutely. Now, when we look at the clinical research that's been out there and some theoretical research that's been published, we look at various ways to modify lenses to ensure that they may be posing less risk for hypoxic changes to corneas. So in a theoretical system that was published by Lagis and Afe, what they really were looking at was a theoretical scleral lens system. So the scleral lens plus the post-lens tear layer making up a scleral lens system. And what they had used were the Harvard Bonanno and the Holden-Mertz criteria of oxygen permeability and what was necessary, what DK level was necessary to keep a cornea from swelling over a 12-hour period, daily wear time. And what they were finding was to meet these criteria, which were 24 and 32 respectively, they needed to be able to, with the scleral lens system, have a DK over T greater than 32. So when we looked at this, the way to achieve that was by using the highest DK material available, so greater than 150, with a maximum center lens thickness of 250 microns, and with a fit that didn't exceed 200 microns. Now there's since been some more research, some more real-world research from Meng Lin and her colleagues at Berkeley that found some of these factors didn't truly factor into into corneal responses, or didn't quite correlate with corneal responses. But when we take a look at the theoretical and we turn that into a simple formula and look at dk over t, in theory, we're looking at, the thickness of the lens divided by the thickness, or excuse me, the dk of the lens material, and including the thickness of the post-lens tear layer with the dk of tears. So what do we have the options to kind of change? What we're looking at in a lens is we can change the characteristics of lens thickness by one, specifying that we want a thinner lens, or two, modifying base curves. Because we're not landing on a corneal surface, we're able to kind of change those base curves to modulate the prescriptions that we need, so we can change that thickness and make it thinner. We can control how close we get to the cornea to make our vaults more minimal, and we can control our lens material decay by going from an 80 dk to like 160 dk. Now, the one thing that is not defined in that theoretical formula, which may contribute heavily to the findings that Ming-Ling had, is the tear exchange. So what happens to tear exchange in a scleral lens? And when we look at these individuals with compromised corneas, we are certainly more prone or more wanting to have tear exchange in these individuals, so that we're certainly not cutting off that fresh oxygen from flowing into the back of the lens underneath the lens haptic. So we need to kind of look at tear exchange and say, is this something that's extremely pertinent in these individuals with ocular surface disease and these fragile corneas? Now, with many of these individuals who are very, very sick, we do have a balance that we need to strike, because if we do get a lot of tear exchange many times, and we've seen this many times in our clinic, and many others see this as well, but we'll see that there is particulate buildup when we're getting a extreme amount of tear exchange. So it's kind of a balance between healing of the eye and vision to kind of, do we trap out more of this debris because this is an individual who has, mild ocular surface disease versus somebody who has severe or advanced ocular surface disease and has a very fragile cornea. Again, we're looking at the risk and benefit here of getting more oxygen underneath that lens so that we can keep that cornea a little healthier.
And here we really want to look at limbal clearance too. We don't want excessive limbal clearance that could lead to excessive post-lens tear reservoir debris, nor excessive corneal clearance. However, we do want a sufficient tear lens reservoir in order to protect the entire ocular surface and, of course, avoid any corneal touch.
Exactly. And when we look at kind of chamber debris, we can look at two types of chamber debris. There's exogenous and endogenous. So basically, is it coming from outside of the lens, or is it coming from underneath the lens? So ways that we can look at this are, simply by painting fluorescein on it and looking at how quickly that fluorescein makes its way underneath the lens. If we have immediate filling of that chamber as we put that on the front surface, we can re-examine our haptic and look for misalignments to say, okay, maybe this needs a more advanced haptic to help line this up a little better and prevent some of that exogenous debris from coming in underneath the lens. We can also look for other signs like frothing, so those very small bubbles that we see in that bottom photo there, indicating that there is some edge lift in that quadrant, and we may need to, again, adjust that haptic. Now, we need to also understand the diseases that we're fitting, because many of these ocular surface diseases are going to have a good amount of cellular debris that is a byproduct of the disease. So increased levels of mucins and proteins coming from the structures underneath the lens, contributing to this kind of filmy or milky post-lens tear layer, like what we see in that right-hand picture there. So as long as we understand the disease that we're fitting, for some of these individuals, we may have to tell them, this is really here to be able to protect your ocular surface, not so much that it's going to be there for, perfect vision. So giving them the right understandings of, why are we using these lenses? What is this lens there to do for you? and what we should have for expectations for visual performance for these individuals. Now, if you have somebody who has mild ocular surface disease and they come in with a post-lens tear layer that looks very milky like that, they're certainly going to have some complaints about the vision. And these patient complaints can range from, again, kind of foggy vision, which typically doesn't have much flux with the blink, kind of irritation that can come in later with the lens wear, and a gradual decrease in vision. So as the particulate kind of gathers underneath the lens, these individuals will also tell you that when they take their lens off, they see a hazy or milky fluid in the lens at removal. So this is another good way to kind of differentiate from, a corneal response to a lens fit response.
Just a few other helpful hints. If a patient has meibomian gland dysfunction, I like to really aggressively treat that first. So at the fitting visit, evaluating the meibomian glands, even flipping the lids, looking for GPC, and aggressively treating that. So I'm a big fan of omega fatty acids also, so adding those in at the fitting visit, so at least they'll have them, they'll be taking them for a few weeks at the dispense visit. And also sometimes in this severe ocular surface disease population, they can have epithelial breakdown, abrasions, recurrent corneal erosions. And so explaining to the patient why you want X amount of clearance under that lens, I find to be beneficial. So, at the fitting visit or at some point in time, you may have too little clearance, and yes, they will get better vision, but I always like to explain why I'm fitting, what the fitting philosophy is, and how that's going to really benefit them over time. So sometimes the vision could be a 20/20 versus 20/20 minus 2, which is, of course, not as clear, and they'll tell you that. But explaining yes, they will. Explaining the process I find is helpful. Touching on edge lift, I always like to ask my patients how the lenses feel. Both initially, they might be aware of them, hopefully not painful. They should be extremely comfortable. But I ask them, if there's any discomfort, where is the discomfort? And they point to a spot on their eye, or I ask if it's diffuse discomfort. But with edge lift, it's pretty, they're very right on. It's pretty obvious. So they say, point to one spot, I look there, there's edge lift. So it does correlate quite well.
Yeah.
Moving on to the next slide, the fluid that we use to fill scleral lenses. So the preference is preservative-free solutions. We do have several options because there have been several studies that show there is limited tear exchange with scleral lenses. So we want to know exactly what our patients are using. And John, I'm sure you've seen your patients use all sorts of things that are not recommended that have preservatives, such as gas permeable lens solution, soft multi-purpose solution. I always like to say orange juice. I mean, it's amazing. Hopefully not tap water.
Yes.
Yes, we've seen it all. So we want preservative-free solutions, stating a recommendation. I prefer FDA-approved solutions if possible. Commonly used, not FDA approved, is nebulizer solution, 0.9%, the Hydrapeg, as you can see here, the upper left. And this can be obtained either online without a prescription or sent to a pharmacy with a prescription. It is important for all of these solutions to dispose of them after a single use. I've been surprised time and time again with patients who have been wearing scleral lenses successfully for many years, and then they come in with a complication, and it's because they're reusing the solution. Some of the solutions have enough in there that they can reuse it to fill both lenses. So I educate my patients that they can recycle or throw it away, whatever wording you want, but the single-use containers, they need to throw it away. Now, PuraLens comes in a bottle, and that needs to be disposed of within 2 weeks.
Perfect. So when we look at, insertion fluids, we always wonder, what sort of adjunctive fluids can we have? Each individual, and I've seen various different variations from various different patients of various cocktails that they like to put into the back of the lenses. They find that, if we use a thicker solution, we get less tear mixing underneath the lens, so we get less of that debris over a period of time. We've also had, some individuals where we've used autologous serum in the back of the bowl in a dilute form to kind of get those growth factors under there to help heal the cornea in those severe patients, especially the ones with PEDs or persistent epithelial defects. And with those individuals who maybe, their risk-benefit ratio tells you that, hey, this individual needs to wear a lens overnight and use the 2x2 strategy, using a preservative-free antibiotic in the back of the lens to be able to kind of fend off any sort of bacterial keratitises that may form while that epithelial defect is present. All those adjunctive fluids can certainly be used in these individuals with great success. But then we kind of ask ourselves, what does the future hold for insertion fluids? Obviously our tear film is made up of quite a bit more than just saline, and it has various different factors in it, from growth factors to various nutrients in it and various ions. So what we're looking at is, can we get nutrient rich or electrolyte rich or oxygenated solutions that can be put in underneath the lens? A doctor out of the Netherlands had showed me this interesting electrolyte rich preservative-free artificial tear that they were getting. They had found quite a bit of success and ended up changing many of their patients to it and found a resolution of epithelial bogging with that. So there's a lot of various things that we can look forward to in the future of these adjunctive solutions for being in the back of these lenses. Now, to Melissa's point, when we get to corneal clearance on these individuals, this is kind of a Goldilocks situation. We don't want too much, we don't want too little. We want to make sure that we're clearly getting over that limbus, though, and making sure that we're not causing insult there, and we don't have so much of a suction or excessive clearance that we're pulling tissue underneath there or causing a kind of suction effect, which will end up with more debris showing up underneath the lens. So if we have insufficient clearance, will clearly cause insult there, that limbal margin, like what we see at the left-hand picture there. And if we have excessive clearance, we can see that that conjunctival tissue being pulled underneath that lens in those right-hand photos there. So let's go ahead and go to corneal clearance and changing geometries. So when we look at geometries in the chamber, this is how we can kind of overcome those challenges with corneal clearance. For example, this individual, basically what we're fitting on them is a 45 diopter base curve. And what we've done is just simply increased our back octed zone diameter by 0.5 and steepened our mid-peripheral curve by 2 diopters. We're able to increase central vault, but more importantly, we're able to get over our limbus much easier in these individuals. So being able to make those changes and understand that the geometry in the chamber certainly matters for these individuals to get over those limbal obstacles. Now, when we get to, go ahead.
Oh, speaking with your laboratory consultant, if you're unclear exactly how to do that with a specific lens design is really helpful.
Absolutely, absolutely. Making sure that you're in touch with your consultant will absolutely make your fits better, and understanding what you can do and can't do with certain designs. Now, like we were saying before, lens haptic issues, these issues will come up with lens awareness, irritation upon insertion, possible gradual decrease in vision because of particulate coming in there. If the lens is too tight, we end up with aches after lens wear, impression rings that are that are present after we remove the lens. We may get bubbles if we have way too much edge lift, kind of leading to channeling into the back of the lens, allowing bubbles in, and we can have difficulty removing lenses like what we see in that upper left-hand photo there. Now, when we start looking at troubleshooting lens diameters with these individuals, I have chosen to take a philosophy of, using a lens diameter that's proportionate to the extent of the eye that's affected. So if we have panocular disease or ocular surface disease, I'm using a much larger lens to cover more of that more of that ocular surface so that we can get more protection. Whereas if I have disease that's more contained to just the cornea, I'm using a smaller diameter and kind of trying to just cover that cornea itself. So if we're seeing these signs, and using our vital dyes here is very important, we want to help to cover those areas to make sure that we're getting our largest amount of ocular protection. Now, when we go to these larger diameters, we know, due to the various studies that have been done, especially by the ones at Pacific University by Caroline, what we have is as we get larger, we get more and more asymmetry and toricity of the scleral shape. So as we go from a 16 or 15 millimeter landing zone out to a 20 millimeter landing zone, we can see that we get more and more asymmetry. And as we get more asymmetry, we're going to need more advanced haptics to be able to align those. Now, there are ways to help us in our decisions for what sort of shapes we're going to need, and we can use advanced imaging systems like these profilometry devices that have come out from EGLIT and precision ocular metrology to be able to map out the scleral shape and help us give us an idea of what are we fitting at those various chords and what we need to use to overcome them. Recently, the Scleral Shape Study Group had published this study in, I believe it was, Journal of Contact Lens Research and Science, and what they were finding were various different patterns of the way these scleras are shaped. So they were looking at sagittal deviation, so comparing various portions on the sclera at a 16 millimeter chord and how much difference they have in various depths from each side, and then looking at the symmetry of that. Is it a symmetrical shape, an asymmetrical shape, and then is it a recurrent pattern? And what they found was very few eyes actually had a spherical shape. Many of them had a toric or an asymmetrically toric, and a slightly less amount had a irregular periodicity to them. So when we look at that, what that's telling us is that we need to utilize our more advanced haptic shapes. So we're looking at things, our kind of traditional haptics are sphericals, and those are very common. We can get torics, which are now very common as well, where we have a steep and a flat meridian to the haptic. We also have quadrant-specific designs that are available, and those are extremely important once we start getting into our larger diameter lenses, and our less available haptic designs would be our octet or our 8 meridian, submeridian lenses, and our elevation-specific lenses where we can get anything anywhere. Now, as far as kind of unique elevations that you may find in these individuals, when they have these severe diseases, they're going to come in with various blebs from having glaucoma surgeries, from having various uveitic responses that may increase their pressure and necessitate the need for these various surgeries. They'll have shunts, they'll have pingueculas, they may have tectonic or patch grafts, various conjunctival scars, and some blepharons. And we need to be able to overcome these elevations, because with these unique elevations, we can have complications that arise, such as focal compression or conjunctival hypertrophy or erosion over tubes, like we see in that bottom right-hand photo. So we need to use our advanced haptics to overcome these things like microvolts, which are small elevations in either the periphery of a lens or even internally to the lens, using notches and truncations to be able to get around and avoid these obstacles, using quadrant-specific designs to help align over the top of them, and even using our various diameters to either jump over these elevations or to be small enough that we're inside between the limbus and the elevation that we're trying to avoid. So in this individual, this was just an example of a notch that we used to avoid this pinguecula. Now, when we have extremely complex geometry for individuals who may have multiple obstacles, like multiple blebs or shunts or tectonic grafts, or have undergone, open globe trauma like this eye that was on the right, this individual, after their accident, had lost the ability to blink. What we did was go ahead and fit them with a impression molded design, which was able to overcome the extreme geometry. And this is actually the render of that lens on the left. You can see the extreme irregularity in that haptic, and then you can see how well that fits in the right-hand photos there. The other thing that we need to look at in these individuals, though, that's a very common complaint, is fluctuating vision, and this really comes into lens surface issues. So having vision that varies from blink to blink with temporary resolution with installation of artificial tears or blinking. And these individuals may tell you, I have to take my lens out multiple times a day, give them a rinse, rub, reapply them, and they're good for a little bit of time, but then the buildup starts to form again, or it may be a more immediate response. And these individuals may need to have various complications addressed, like take a look at their lids, and like we were saying before, look at the unaddressed lid in ocular surface disease and look for dysfunctional tears. Many of these individuals will have quick tear breakup times, saponified tear films, blepharitis, meibomian gland dysfunction, or even absent tear prisms. And we really need to look at our underlids for giant papillary conjunctivitis and lid wiper epitheliopathy.
John, just backing up a little bit, excellent job on all these slides for the importance of ocular shape and scleral shape and the haptics. So especially in this patient population that we're talking about, the severe ocular surface disease population, we really want to utilize our toric or quadrant specific or impression based technology, because we want the periphery of the lens to align with the sclera to avoid any sort of debris coming in. We don't want any edge lift. We don't want any limbal compression, especially in this group of patients.
Absolutely, absolutely. It becomes extremely important in those individuals. Now, when we start looking at lens material has a big factor in our wettability and our ability to keep these lenses from suffering from front surface issues. Lens material is mostly a practitioner's choice, but it's limited by the lab's supply, who they work with, and what buttons they have. And the property that we're really interested in these lens materials is the wetting angle. Obviously, on the right-hand side, we can see various different droplet wetting angles there. So the droplet is resting on the surface of the polymer, and looking at the degree at which it spreads over the surface, we can measure the angle between the polymer and the droplet itself to be able to come up with the wetting angles. So in figure A, we have about a 30-degree wetting angle, figure B, about a 20-degree wetting angle, and in figure C, about a 5-degree wetting angle. So the lower the wetting angle we're able to achieve, the better wetting we can get for these individuals. We want to be able to get a nice sheet of tear covering that front surface. Now, the manufacturing really matters, and this isn't so much a problem nowadays as much as it was back in the day, but feeds and speeds of how fast you turn your lathe and how much heat is created is extremely important to the way that the polymer reacts. So if we hit this polymer with too much feed feeding the polymer into the diamond too quickly, or spinning at too fast of a rate, we end up creating unnecessary heat, which can change the properties of that polymer, causing it not to wet. So at this point, most of our labs are extremely good at manufacturing lenses, and this isn't a problem like what it used to be when these lenses were hand cut. Now, cleaning regiments do matter, and you need to know what you're using for various different polymers and for various different finishes on these lenses. We can utilize our abrasives, our non-abrasives, our enzyme cleaners, and even multi-purpose solutions. And some individuals have found that off-label use of multi-purpose solutions, soft lens multi-purpose solutions, have been pretty beneficial for these individuals due to the HA that's in the various soft lens solutions. But it's extremely important to know what you're using. Generally, an abrasive cleaner is going to damage a plasma-treated lens, and is certainly not something that you're going to use in a Hydrapeg lens. Now, when we get to lens treatments and lens coatings, we're all familiar with plasma treatment, which is truly a treatment of the material. What you're doing is you're using plasma state oxygen to bombard the surface of this lens and really clean it and strip it of all the pitch and polish and all the manufacturing debris that can collect on these lenses during the process. And as a result, what it does is ionizes the very surface molecules on that lens. Plasma treatment, however, is a very short-lived process for most of us. Usually within a few cleanings, the effect is lost. Now, there is a true coating that does exist that's actually applied after a plasma treating process. So the advanced coating, which Mellissa will speak about here, is Tangible Sciences Hydrapeg, which is a polyethylene glycol solution, which is basically grown on the surface of the lens and encapsulates the lens in that polyethylene glycol material to be able to hold moisture to the lens.
So Tangible Hydrapeg, as John mentioned, is a 90% water peg-based polymer mixture that is permanently bonded to the surface of the contact lens. So it shields the lens and the ocular surface and tear film, so it helps sweatability, it improves surface water retention, improves lubricity, and here you can see in some studies, you can see it reduces proteins and lipids. Tangible Hydrapeg helps with end-of-day comfort. It also helps improve and lessens fogging, improves comfort, and in patient preference, they prefer lenses with Tangible Hydrapeg. So if you haven't tried this previously, I would recommend that you try to order scleral lenses with Tangible Hydrapeg. Most manufacturers in the US do have this technology, and it's been so beneficial for so many different reasons, as you can see here in our patient population. But yes, you can look at the studies, but I would encourage you to try it yourself and get your own experience. So as far as solutions go, it's a little bit different with lenses treated with Hydrapeg. So we do not want any alcohol-based cleaners. We don't want Menacon Progent, which can take off the coating. The approved solutions are multi-purpose solutions, such as Unique pH and Simplus, where rubbing of the lens is needed, and also hydrogen peroxide-based solutions, such as ClearCare or ClearCare Plus with Hydroglide. The tap water we do not want to use at all with Hydrapeg. It is abrasive, and any alcohol-based cleaners and Menacon Progent itself actually takes off the Hydrapeg, so we do not want to use that and don't want to use enzyme cleaners. So specifically in this patient population, I have many patients that are using these cleaners, and I tell them at the fitting visit when I'm planning on ordering lenses with Hydrapeg, and again when I'm giving them the lenses, that they should not use these cleaners. The Boston cleaner itself is also abrasive, and so we don't want any abrasive cleaners at all.
Now, as far as external factors that come into these fits and become a factor, many of these individuals who have exposure keratitis or, nocturnal lithalmus or, various different factors that are going to leave their eye to desiccating overnight, many of these individuals use various ointments, and the ointment that you're using will matter for a scleral lens. If we're using an oil-based ointment, that'll be in there in the morning when they put their scleral lens on in the morning to protect their surface, that oil can possibly make its way onto the front surface, creating a non-wetting situation. So in those individuals, I switch them from a petroleum or an oil-based ointment into a water-based ointment. So in the morning when they wake up, they can use some of their saline to just rinse the eye out and then go ahead and proceed to put the lens on without having to worry about it affecting the hydrophilicity of the lens. Another thing to worry about is cosmetics and various moisturizers and oils and creams and lotions, and how they handle their lenses and how that might affect the front surfaces. For your patients, Mellissa, do you find that the individuals with ocular surface disease are typically not using cosmetics as much anyway because of scarred lid margins and other things like that?
It does vary, of course, in the severity of the ocular surface disease and the patient, but I find that many of my patients are asking me for recommendations as far as mascaras and eyeliners and oils and creams, and there are many really excellent products out there. Some products that are really helpful are those from the company iEco, facial products that are also helpful around the eyes, the Blink products like the Blink mascara, which goes on like little sheets onto the eyelashes, are helpful. So when patients use artificial tears, maybe throughout the day over their lens, it doesn't come off at all. But I always like to know what my patients are using, and really for all patients, not applying eyeliner close to the eye, removing makeup at night, and always applying oils, creams, lotions, and makeup after scleral lens insertion.
Excellent. Now the last section here will be on lens application. Many of these individuals that we see in our practice who have inflammatory conditions, especially rheumatoid arthritis, we end up having some difficulty with their ability to be able to have dexterous stability to put a lens on or remove a lens with ease. And there's various different removal and application devices that can help with scleral lens application and removal. So we have our traditional DMVs, which we all know and love, and we have a single finger ring that has come out from a company called Q-Case. This is the Easy Eye inserter, and that helps to balance a scleral lens on the single finger, as well as using simple dental rubber bands, as well as O-rings can be used to help with that single finger insertion to help balance that lens. There are also kind of lid controlled and head guided devices that you can use with the Dalsey Adaptive C Green, so individuals can hold their lids open and focus on just holding their lids and then moving their head down to the scleral lens to be able to apply it. And that has been tremendously helpful for our individuals who have severe rheumatic disease that have problems there. And now there is also a semi-automated device, this contact lens what is it called? Insertion and removal apparatus. And this has been a very interesting device that has recently come onto the market to help these individuals who have kind of dexterous problems to hold their lids open for them and help aid in applying the lens. Mellissa, I'll let you speak to the experiences that you've had with these devices.
Yes, so the C Green lens inserter is one we have in our practice. I use it probably the most often. So some of these patients in the severe ocular surface disease have advanced rheumatoid arthritis, or a high prescription, or they have tremors or missing digits, and so that's really helpful. So we do have it in our office for patients to try. I've also had multiple patients make their own, which has been really fun, and they're so creative. It's really amazing. The easy lens inserter we also have, as well as the orthodontic rings. So we have all of these tools to help our patients to see sort of what works for them. And especially in this group, it's so important to teach and reteach application and removal of scleral lenses. I believe that is the most common complication right now of scleral lens wear. So you can have an ideally fit lens, the patient could be happy all day long, but if they can't insert it and remove it with ease, they're not going to want to wear it. But having these helpers, just for all patients in general, is extremely helpful and beneficial. I do want to thank all of you for attending our webinar tonight. It has been such a pleasure to be here, and I'm sorry we don't have time for questions, but we will respond to all of your questions. We do have all of your information, so thank you so much.
Just a couple quick closing statements here. Thank you guys very much for a fantastic lecture. Everybody can expect a survey to come out tonight or tomorrow. You can offer some feedback if you have any on the lecture, and then within 24 hours we'll send out a quiz that'll have to be completed and sent back. There'll be instructions on where to send that quiz and how to fill that out. That's necessary for COPE credit if you want to receive COPE credit for this this webinar. So expect those. We'll have another set of webinars next year brought to you by the Scleral Lens Education Society. So keep an eye on your inbox for dates and times for those. Have a great holiday season, and thanks again, Melissa and John, for a great webinar.
Thank you.
Thank you.